Hi everyone, thank you so much for joining us for the July webinar. Today's webinar topic is, are you paying too much for preventive care? Our webinar today is presented by Chief Medical Officer and Compass co-founder, Dr. Eric Bricker. With that, I will hand it over to him.
Thank you so much, Alex, and thank you to all of you for joining today for our webinar, which I am super excited about. And our Compass webinar topic for today is of major frustration for not only employees, but oftentimes the HR staffs at companies and for broker benefit consultants as well. So as Alex said, I am Dr. Eric Bricker. I'm a general internist. I'm the co-founder and chief medical officer of Compass Professional Health Services. There's a picture of yours truly right there. And I did my residency training at Johns Hopkins in Baltimore. Actually did some research on diabetes and hospital-acquired infections while I was there. And actually in my prior life was a hospital finance consultant before going into medicine. So I was dealing with all the same claims issues that you as employers or broker benefit consultants or insurance carriers are dealing with. But I was on the flip opposite side. I was on the doc and the hospital side of the claims, and really learned a lot about the administrative chaos that is healthcare, and really wanted to take a lot of that insider knowledge directly to companies and their employees after finishing residency and going out and practicing. I also write a blog as well. It's had honorable mentions for a couple of years. I know many of you are subscribers. We actually have over 5,000 subscribers to the blog, and we also have over 2,400 members as part of our healthcare price transparency group on LinkedIn as well. So feel free to either subscribe to the blog or join that price transparency group on LinkedIn, where you'll also get blog messages that way as well. And as Compass, as many of you know, is tools and support for healthcare consumers that takes the form of providing in-network price and quality transparency, healthcare consumer advocacy, or a concierge through our Health Pros who interact with the employees. We also help employees with their annual preventative exams, which we're going to talk in detail about today, and really steering folks to the highest quality providers in their area. Compass, we're actually up to over 2,200 clients now. Many of the big household names that you see here: T-Mobile, Atmos Energy, Sabre, which used to run Travelocity, but they do the software for the majority of the airline industry. Southwest Airlines, Chili's and Maggiano's Restaurants, Dillard's, manufacturing firms like Overhead Door, Barry Waymiller, universities like SMU, trucking like Belton Truck Lines, retail like Nebraska Furniture Mart and Michaels, utilities like Energy Future Holdings, which is the power company here in North Texas. We've actually recently added several large municipalities as well. So wonderful clients. Many of you are on the phone today, as well as their broker benefit consultant are on the phone today. So really appreciate being able to work and partner with all of you. So are you paying too much for preventive care? That's what we're going to talk about today. And so let's go back to one of our favorite topics, which is the Affordable Care Act. So how do we get to preventive care being covered at 100%? So here's our brief history lesson for the day. So the Affordable Care Act in 2010 stated that insurance plans must have no out-of-pocket cost share for preventive services graded A or B by the U.S. Preventive Services Task Force, the USPSTF. Now, that begs the question, what's the USPSTF? Well, it's a part of the Agency for Healthcare Research and Quality, otherwise known as AHRQ. Some of you are maybe familiar with that acronym, right? If you're dealing with government agencies, you have to deal with a whole bunch of acronyms. Then that begs the question, well, what is AHRQ? Well, AHRQ is a part of the Department of Health and Human Services. So there you go, Health and Human Services to AHRQ to USPSTF, and that is the body that then generates the recommendations and the grading system. So then that begs the question, what is this USPSTF grading system? Okay, so what they do is they convene a quote-unquote panel of experts who are largely clinicians. They go out and they survey the literature and the evidence around preventive care, and I will tell you that they will also take into account quote unquote current consensus opinion, or so what everybody believes to be the right thing. And that's a little dangerous, right? You really want to do it based upon evidence as opposed to just your quote unquote consensus findings, because certainly medical thoughts change over the years, and certainly what we used to think in the past was good, we don't think that's good anymore, and vice versa. So, but they try to do it based upon the evidence as much as possible. And then when they survey the evidence for each particular test or screening exam, they'll say, okay, if it's a grade A, then it is recommended preventive care with a high degree of certainty that there is a substantial net benefit. An example of that would be colorectal cancer screening. Now, a grade B is also recommended preventive care that is high certainty that the benefit is moderate. So the difference between A and B is A is substantial benefit, B is moderate benefit, or just moderate certainty that the net benefit is moderate to substantial. And actually, breast cancer screening with mammograms actually falls under grade B. Now, grade C recommends selectively offering or providing to individual patients based on professional judgment and patient preferences with at least moderate certainty of small net benefit. So this is the kind of meh recommendation. And so here, this would be like fall risk screening in older adults. So it doesn't necessarily apply to an employee population, but for seniors, doctors don't necessarily need to screen all of them for fall risk. But if they look like they're frail or they might have balance problems, well then that might be a good person to screen for a fall risk. Now, there's grade D, which recommends against the service with moderate or high certainty of no net benefit or that harms actually outweigh the benefits. So in this case, prostate cancer screening. So prostate cancer screening actually used to be kind of left up to the physician's discretion, maybe yes, maybe no, but now it's actually no, don't do it. It's of no benefit, and the harms might actually outweigh. So it's how in the world could a screening test be harmful? Well, when you screen, sometimes those, which is done by a PSA blood test, that you can get, quote unquote, false positives, which is mildly elevated PSAs, and then you need to do a quote unquote prostate biopsy where they actually need to take prostate tissue. Well, there can be complications from that prostate biopsy. I mean, it actually, involves a needle. There could be infection. There could be excess bleeding. So here, the gentleman might have no prostate cancer, no risk of prostate cancer, but they might have a complication as a result of a screening test that was highly ineffective. So not all screening tests are harmless because they sometimes lead to subsequent follow-up procedures which could be harmful. So it's important to keep that in mind. Then there's also grade I, which concludes that current evidence is insufficient. So basically, I stands for insufficient to assess the benefits of and harms of the service. Evidence is lacking, there's poor quality, conflicting balance of benefits and harms cannot be determined. So two very common tests that are quote unquote screening that a primary care physician might order during an annual physical are thyroid function tests and vitamin D level tests. Those are both blood tests. So those are not A or B. So they are, by and large, not covered at 100%, and we're going to go into more detail about that later. So in total, the USPSTF reviewed 95 tests and interventions and only considered 56 of those to be grade A or B. Now, so fine, you've got those 56 that are A or B, that they're covered at 100%, but it's not for everybody. So only certain people will fit within the requirements to be covered at 100%. And so what are those requirements? Well, some are gender-based. Obviously, breast cancer screening is only for women. Now, breast cancer actually is incredibly rare in men. So theoretically, you could screen men for breast cancer, but it's so incredibly rare that screening for it is essentially ineffective. So in this case, they only cover the breast cancer screening for women. Or it could be age-based, number two. So high cholesterol screening. It's recommended for men over the age of 35 and women over the age of 45. So someone who's 19, they're quote unquote an adult, they don't go to their pediatrician anymore, maybe to get an annual physical at an internist, they can't necessarily just draw their cholesterol. Now, it's also based on individual risk. So in this case, high cholesterol screening, men and women 20 and older, see they drop the age from 35 and 45 down to 20, if at increased risk for coronary heart disease. Now, what are the risk factors of coronary heart disease? Hypertension, diabetes, and obesity are three big ones. So if someone has, let's say they're a type 1 diabetic, unfortunately they became diabetic at the age of, let's say, 7, and that when they are then 20, it makes complete sense for them to also have their cholesterol checked. They don't have to wait until they're 35 or 45. Next is the frequency. You can't do every test like every month or every year. So for example, colorectal cancer screening for a colonoscopy is only every 10 years. So not only does it have to be grade A or B, but then the person further has to fit within each one of these appropriate buckets for the test. Now, here are the 5 most common causes for out-of-pocket costs. So at Compass, we highly encourage our own employees and the employees at our clients to go get annual physicals. And so part of the service that Compass provides is to hold people's hands through what out-of-pocket costs might be generated, sometimes on purpose or sometimes in error as a result of those preventive annual physicals. So here are the 5 most common causes of those out-of-pocket costs that we see. So 1, the screening does not fit within those age, gender, individual risk, or frequency guidelines. Now, I will tell you that individual insurance policies have to cover the grade A or B, but some insurance policies are actually, quote-unquote, more generous regarding the frequency. So, for example, there are many insurance plans that as long as it is a screening colonoscopy, that the person doesn't necessarily have to wait 10 years, that it would be covered every year. And the thought there is that people really are not going to abuse getting colonoscopies more frequently than they should. So they're not going to split hairs about how many years it is, and they're just going to increase the frequency. Now, I will tell you that will vary by the insurance policy, but that's an important point to know. I want to pause here too and say that as we go along, if you have questions, please also type those in, and I will do my best to add those at the end or address them at the end as well. So please ask questions if you have any. Okay, so number 2, tests that are not grade A or B. So screening for hyper or hypothyroidism by measuring what's called the thyroid stimulating hormone, or the TSH, that's a grade I, and so that is not going to be covered. And then another common one is screening for vitamin D deficiency. Again, grade I, not going to be covered. So here is where a lot of primary care physicians are like, oh, I need it's good clinical practice to do this. But when a panel of expert physicians examined the evidence, they did not find evidence to show that those are good screening tests. So, and that's important, that just because a physician has a quote-unquote opinion about something, that to the extent possible, it's good to have those opinions based in evidence in the medical literature. And so in this case, those tests are not going to be covered. You can still get them done, and they're not very expensive. Depending upon your policy in the lab, it might only be like $17 or $18, but it's not going to be covered at 100%. Okay, number 3, discussing a specific symptom, complaint, or condition during a preventive office visit. So this isn't for the screening test or procedure. This is for the preventive office visit itself, right? Because the office visit might cost anywhere from, $80 to $150 allowed amount. And that's going to be paid by the insurance company or your self-funded employer, but then it's going to be paid by, it's going to go to your deductible or coinsurance or your copay if it's not, quote unquote, considered to be preventive. So the first bullet here, to be processed with no out-of-pocket cost, the bill needs to have a general medical evaluation diagnosis code on the bill, right? So every bill has to have a diagnosis code, and if nothing's wrong with you, there's still a quote-unquote diagnosis, and that diagnosis is general medical evaluation. Even if you do have a chronic condition, let's say hypertension, that specific visit still needs to be coded with a diagnosis code of general medical evaluation. So, let's say you're perfectly healthy, but if you say you have a sore throat, the visit will likely be coded with an ICD-10. By the way, that's new as of October, right? We used to use ICD-9, now we use ICD-10. If you say you have a sore throat, you're going to have an ICD-10 code of JO2.0, which is strep throat, or maybe JO2.9, which is acute pharyngitis, unspecified, right? You can have a sore throat from something other than strep throat. And if they code those visits with one of those 2 codes, it is not going to be processed as covered at 100%. So the insurance carrier's claims processing system will pick up the codes and translate it into a sick visit. The preventive visit is no longer covered at 100%, resulting in out-of-pocket costs. So certainly, if you want to discuss a specific complaint or what have you, please do. But just know that is then not going to be a preventive visit, and it's important to actually, and we coach our patients or our members this when they go to their visit, be like, look, I am here for my annual physical, for my preventive visit, and I want it to be coded that way. And we really found that the majority of the time that the physicians comply. Sometimes there's miscommunication and they don't. However, it's important to set that expectation up front with the physician. Okay, number 4. Lab test ordered includes other non-screening tests. So here they order the blood work, but many lab tests are in batches. So here's some examples of batches. The first one is a comprehensive metabolic panel, or a CMP. So basically the lab rec form, or if they're using the computer, the rec form on the computer that they're clicking the buttons on, it has like a ton of boxes for all these different types of labs. And one of the most common labs that's drawn is a comprehensive metabolic panel. And it screens for things like kidney function with your creatinine, your electrolytes with potassium, sodium, chloride, bicarbonate, liver function with AST, ALT, bilirubin, alkaline phosphatase. And so the CPT codes for the labs must be for the USPSTF covered test only. So the comprehensive metabolic panel also includes glucose. So a lot of times the physician's like, oh, well, yeah, let's check their glucose, and let's just go ahead and check all that other stuff too, since we're drawing the blood anyway, just to make sure. And so instead of, you can just check for glucose, you can just check the glucose box, but instead of just checking the glucose box, they check the CMP box, and then that CMP is upwards of $150 to $250, and the USPSTF is not going to cover a CMP at 100%. Okay. Lastly, number 5, coding or billing complexities. This, to this day, is still a challenge for many of our members. Separate anesthesia bill for conscious sedation during a screening colonoscopy not processed as preventive. So I will tell you, the majority of the time, the gastroenterologist will perform their own conscious sedation during a colonoscopy, right? Because you don't want to be awake, you want to be asleep. However, if the gastroenterologist uses a separate anesthesiologist, the anesthesiologist is going to do their own separate billing, oftentimes with their own separate billing office and billing company. And anesthesiologists, they don't really do quote-unquote preventive anything. So they're not used to quote coding anything preventive. They probably don't even know how to code something preventive. And guess what? They end up never coding that conscious sedation as preventive. So that when it's submitted, sure, the colonoscopy is covered at 100%. Sure, the gastroenterologist professional fee is covered at 100%. But the anesthesia, which could be upwards of $800, then would fall to deductible or coinsurance. What a mess. And so that's where Compass will actually work with the carrier and or the anesthesia billing company to then have it resubmitted and reprocessed appropriately so that it is covered at 100%. Okay. So then this begs the question, a lot of employers do on-site biometric screening. And now we have a lot of other clients that say, okay, we're going to have all of our employees just go to the doctor's office for their annual physical and have their blood drawn at the doctor's office. Some companies offer employees the option of either one. So now let's weigh the pros and cons of the on-site biometric screening versus the doctor's office. Well, certainly it's much more convenient to have the biometric screening for the employees. However, I will tell you that many employers just do a broad brush of, okay, well, let's just screen everybody for their high cholesterol, triglycerides, glucose. Let's screen everybody for their high blood pressure. Now, again, if you have a lot of young employees in their 20s that don't have any high risk for coronary heart disease, well, then they actually don't need to get their blood drawn. And so here, that literally means that the company is, subjecting the employees to getting stuck with a need. Now, oftentimes the biometric screening company, they have a separate billing process, and you have to pay them, X number of dollars. So one, you're kind of paying for screening tests you don't even need. And then two, well, shoot, if you're an employee and you don't need to get stuck, a lot of people are like deathly afraid of needles. And so they might be like, well, I don't really understand why I'm getting stuck with this needle. So just know that if it's done at the doctor's office, the doctor's going to weigh, okay, well, given your risk profile, let's say you're a 26-year-old man or woman, well, then maybe you don't need to get screened for those, and that's fine. So there's probably greater clinical appropriateness if you do that at the doctor's office as opposed to a broad brush approach with on-site screening. Okay, so that's one pro and con. 2, on-site biometric pro is that it saves time off of work, it saves travel. Again, you avoid those billing problems because if you're doing on-site biometric testing, you're not going to be testing for TSH and vitamin D, so you don't have to worry about that. So that's where the con of the doctor's appointment is that, yes, it does require time off work, probably going to be at least a half a day. 2, they got to travel, which depending upon the location of the employer might be inconvenient for the employee. And then 3, those billing problems that we just talked about in the above 5 points. And now on-site biometric cons and doctor appointment pros are, well, who and what should be tested is specific to the individual, and that works out better at the doctor's office. And then here's the big one. It allows for counseling, right? So if there's an abnormal value, then the doctor can actually talk to them about modifying their behavior, or maybe doing subsequent follow-up tests, or maybe even starting them on medication. You can see that next bolus treatment. Oh, shoot, your blood pressure is 180 over 110. That's too high to lower the salt intake in your diet. I mean, we got to get you on some blood pressure medication pronto. Likewise, if your total cholesterol is like 290, hey, maybe we can't wait for lifestyle modification. Maybe we need to get you on cholesterol medication right away. I mean, obviously, as clinically appropriate, and then obviously follow up. Okay, fine, we get you on this medication. Let's get your blood pressure checked in 2 weeks or a month to make sure that it's actually coming down, or let's check the cholesterol in 3 months to make sure that it's actually coming down. And then also it establishes a relationship for future visits, right? So if you're a quote unquote established patient with a doctor, oftentimes you could call in for same day or next day appointments, which would allow you to avoid having to go to the ER or the urgent care center. But they won't do that if they've never seen you before. So they need to kind of see you once a year to be like, okay, Joe or Jane is an established patient here at the doctor's office. And that's basically a much more efficient and effective way to access the healthcare system, is through the primary care physician, as opposed to through the ER urgent care all the time. And again, to this point, so this was a study in Health Affairs from 2008 that said that U.S. adults that had a primary care physician had 33% lower healthcare spend than those who see only specialists, right? This whole self-referral to specialists ends up costing more. You can see this is with no PCP, and this is with a PCP. And that allows that primary care physician to quarterback or coordinate all the specialists. Oftentimes, the cardiologist is not talking to the gastroenterologist, is not talking to the orthopedist, is not talking to the rheumatologist. So if you happen to have all four of those subspecialists and not a primary care physician, then no one's really organizing all four of those specialists. So it's very important to have that sort of clinical quarterback, if you will. I mean, as an internist, that's what I would do all day long. And I'm kind of strange. I actually enjoy doing that. I get tremendous satisfaction out of doing that. And I would really see patients that didn't have a primary care physician really fall through the cracks. And specifically at Compass, then, we have our Compass Health Pros. So you can see this is actually a picture of one of our health pros who actually did go to the University of Wisconsin here. You can see the badger there in the background. And the employees interact with this health pro by phone or by email or our online member portal, and they really hold their hand through, okay, well, let's find a primary care physician that fits your specific appointment availability, location. Let's help you resolve all those complex, billing snafus that might happen. There's a picture of the portal. You can see the Contact Your Health Pro button there. If people want to look up their own doctors or look up their own prices, they can do that themselves. So it really gives them the option for people that, either want to do self-serve or actually work with their health pro. You can see we tie in all these concierge solutions around actually getting your preventive visits. So understanding your benefits, finding great doctors. Let's say you go to a preventive visit and they're like, you know what, you do need to be referred to a cardiologist. Well, then we can help find a cardiologist that meets your specific needs as well. Give you the price and quality transparency so that the in-network prices, let's say you got to be referred out for an x-ray. Well, it might be $50 at one location, $250 at another. Maybe you need to be referred out for an MRI. Again, maybe $500 in one location, $2,500 in another location. Well, that would be good to know in advance. Maybe you are put on blood pressure or cholesterol medication. Well, let's find some generic medications and let's get them through mail order so that it might only cost you $12 every 3 months. I mean, it can be incredibly inexpensive to still get your condition treated. And then finally, whether it's a medical billing problem related to your preventive care or labor and delivery or any other ER visit, what have you, then we can also assist with that as well. And then we can actually track the preventive visits, whether it be the office visit or you can see here the biometric screening on the member portal as well. So people can be like, okay, what do I got to do for my company's wellness program? Okay, log in here. When do I got to do it by? You can see the deadline here of 10/31/14. So you can actually have the employees track kind of their progress, and then we report back to the employer as well if there's any sort of a incentive or penalty associated with it. We then send them kind of report cards as well on a monthly basis. They call them health tracks. So this here, hey, this person's got 2 actions remaining. Hey, they got to get their physical exam. In this case, they're using Vitality to do their health risk assessment. Okay, but then they've got some of their other screenings they've done, right? Cervical cancer screening, that's done. And Compass really then acts as that central sort of administrative medical home or administrative quarterback across all of their benefits. And it really, a lot of times wellness programs in general just have low compliance, like not a lot of people do them. And so it really takes, one, the financial incentive, and then two, just make it really easy for people. And the way that we make it easy is the employer just says, look, the call to action is just contact your Compass Health Pro. And they literally call us up and they say, what do I got to do? And we totally explain what the program is and how it works, and then start getting them linked into the right primary care physician for their annual screening. So then let me end with a couple of real examples at Compass. So we had a gentleman who was just over 50 who received a physical exam in the fall of 2015 as part of his employee benefits incentive program, right? So he had to do physical as part of his program. The primary care physician said, hey, you're over 50. You haven't had a colonoscopy. Let's refer you to a gastroenterologist for a screening colonoscopy. And as colonoscopies are recommended by the U.S. Preventive Services Task Force to screen for colon cancer in men and women over the age of 50. And guess what? Multiple polyps were found and removed during his colonoscopy. Colon polyps are precancerous growth. That's how colon cancer starts. It starts out as a benign polyp, but over a period of 5 to 10 years, it actually transforms and becomes malignant and becomes cancer. So if you remove those polyps, you actually remove the precancerous lesions. So it actually prevented future cancer in this gentleman. And once polyps are found, you are at a higher risk for then having future polyps. So in this case, he needs to be screened every 3 years as opposed to every 10. And then, of course, what happened? Additionally, the member's colonoscopy and the anesthesia for the colonoscopy were processed as diagnostic, which caused him to be billed for the cost rather than be covered at 100%. And then the member contacted Compass because he felt the cost would be fully covered. Compass then contacted the insurance carrier, had the colonoscopy charge reprocessed, so it would be covered at 100%. Compass Health Pro also worked with the anesthesiologist's office to resubmit their claim to be covered at 100% as well. As a result of this company's incentive plan, the Compass member proactively took care of his health. I mean, literally, this guy was prevented from having cancer. Now, granted, he did not march into his HR office and be like, oh, thank you so much for finding polyps in my colon. Of course not. He did not do that. But this really made a huge difference in his life. And so this HR person and this company's executive team and this insurance broker literally prevented a medical catastrophe for this gentleman. Now, let me give you another example. This is at the client level. So we had a Compass client with an annual physical exam prevention program that resulted in 412 additional physical exams for employees compared to the previous year. And as a result, they had 56 people were newly diagnosed with diabetes and received treatment. These people had likely been had diabetes for years and did not know it. We were on a call with the medical director of the carrier, and he was like, I can't believe how many more diabetics you have on your plan this year. And the broker smartly said, well, it's because we had so many more physical exams, and we just found so much more diabetes that was already there. And it turns out that literally every single one of those employees had been at the company at least the previous year, if not longer. It's not like they just were hired, so they had been there. And as a result of Compass, they can avoid the complications of diabetes, including the complication of diabetes are blindness. Diabetes is the number one cause of blindness in America. Heart attack, stroke, and kidney failure. I will tell you that I would see people who would not be able to move the entire left side of their body after a stroke, and it was only then that they found out for the first time that they had diabetes. I mean, that is crazy. I mean, if we, as employee benefits professionals, can prevent that, then that is a huge deal. And so if you do the math on this, 56 divided by 412, that's 14% of that population that had new annual physicals had diabetes, which guess what? That's about the prevalence of diabetes in this particular employee population. Nationwide, it's 10%, but the demographics of this specific employer is in a population that has a little bit of a higher rate of diabetes, and so what do you know? It matches up pretty good. So we are coming to the conclusion of the webinar, and I want to tell you that we have done a major facelift to our blog, and we've added social sharing buttons for LinkedIn and Facebook and Twitter, and we're really focusing on those issues that are important to you, our clients, our prospective clients, and our broker benefit consultant partners about employee health, health plan management, price transparency, employee engagement, helping employees navigate the healthcare system, healthcare trends. We've got a new subscription button as well. So if you have or have not subscribed, then please do so. You can actually put in your email address there at the blog to get it. It's about 2 to 3 blogs a week that I write. And with that, that brings us to the conclusion of the webinar. So I'm going to go here to the questions and see what people have asked, if I can actually read some of these. Okay, you guys asked a ton of great questions. Let's see if I can read through them. I apologize, it's kind of small, but I'm doing my best. Okay, this is a great one. So where can employees go to get a list of items that are considered preventative and should be covered in their annual routine visit? Thank you so much for asking that. So I will tell you that each of the insurance carriers actually have very good sort of one-page cheat sheets. I will just tell you that we at Compass happen to use UHC, and UHC's cheat sheet is good. So you could just literally Google that. And that is, and we even encourage our own employees to actually print out that sheet and actually take that to the doctor's office with them. And the next question is when does the office visit fall under preventive? And again, if you have a chronic condition already, like high blood pressure or high cholesterol, then if you go in, and they might code that visit as, oh, this is a visit for your high cholesterol, but you need to specifically tell them, hey, this is my annual physical. The doctor's going to get paid the same amount regardless. So it doesn't they don't get paid less for doing a physical. It's just that all of their payment comes from the insurance company or the self-funded plan, as opposed to a combination of your copay or full cost of the visit. So, just you have to be explicit about it. And the doctor might say, well, look, we'll do annual physical now, but then come back in 6 months for your cholesterol. But at least you have to have that conversation up front about it. I will tell you, if you say nothing, it's probably going to get messed up. It's probably, it's always best to assume the worst and address it up front. Okay, so the next one is about urine testing. So this is a great one. I will tell you that there are no urine tests that are considered preventive in the U.S. Preventive Services Task Force. So if they collect a urine sample from you, then it's probably not going to be considered preventive. So, I mean, they still might want to do it, and you still might want to talk to them up front. And honestly, urine tests are very inexpensive most of the time. If it's just like a urinalysis, maybe $10 to $15. But again, if they're collecting a urine sample, just know that it's probably not going to be covered at 100%. And I will end it there because we're getting to the end of our time. But I'll also tell you too, please email me if you would like a copy of these slides. I mean, I think this information might actually be helpful to the employees directly or for your fellow benefits professionals. So if you want to email me, ericb@compassphs.com for the slides, happy to send those over to you. We've got more of our webinars that are recorded at our compassphs.com/bestpractices/webinars. So a lot of folks like to watch those webinars just at their leisure, on the weekend, what have you. They're all about a half hour to 45 minutes. And with that, I want to thank you for giving me the most important thing that you have on a Tuesday, which is your time and attention. So thank you so much, and I hope you have a fantastic rest of your day.